I would like to know the aim of photocoagulation in argon laser.
No, argon laser is simply a type of laser. There are other types of laser. What you do is you are photocoagulating to stop the growth of blood vessels.
Oh, okay, sir.
Because if you allow the blood vessels to grow on the retina, eventually there will be a lot of fibrosis and retracting. So you end up retina being peeled upward into the vitreous. You have retinal detachment. So to stop that, at the time there are blood vessels there. Those are not normal blood vessels. When we say blood vessel, we're not talking about the normal architecture. These are new vessels, neovascular. That's why they call it neovascularization.
Yes.
Capillaries start growing up. You have to hit those in that photocoagulation to stop them growing. Otherwise, if you allow, eventually the blood vessels will grow with the fibrous tissue and there will be retinal detachment.
Oh, I understand, Doc. Thank you.
Okay, thanks very much, Andy. And that's basically why we do photocoagulation, not to stop growing of the blood vessels. They will pull the retina off with fibrosis.
Any more question?
Questions, ladies and gentlemen? Bakwaka no vunga. You heard about that say? No.
I hear it from you.
From me?
Yes.
Tapabanson. Lwakwata ensoli muleaka n'obunga iwo bwali bwobeta bwakose. Your friend will eat proper jima. You need to still be porridge. Because we were shy when you were sharing the meal. I'm sure the members in this class, they know what I'm talking about. I'm not a member, but I know a lot of members. Bakwaka no bunga tapabanson. Ngawabaka kwenson tawai kutewe tawai. Questions, ladies and gentlemen, if they are there. Otherwise, we proceed. Pars plana vitrectomy indicated in cases of macular edema. We are still going on.
We can continue.
Hmm?
We can continue.
You can continue. Huh?
Yes.
Yes, I want to continue. Yeah, but where is my lecture? Where is my lecture there, please? Okay. Pars plana vitrectomy, you go through the pars plana. And the reason why you go through the pars plana, there is no retina there. Between the ciliary body, there is a pars plana, then you actually go backward, use the beginning of the retinal layer. So if you go through the pars plana, you are not damaging the retina. But if you go backward, you are putting a needle through the retina, you are damaging the retina. So most of the surgery in the vitreous posterior part of in the posterior chamber is done through the pars plana. They push in light, they push in all sorts of instruments. It's high-tech, the surgery. And this is the pars plana vitrectomy. Pars plana vitrectomy may be removing fibrous membranes on the retina. You go through the pars plana. Maybe you want to go and do laser. Once you've removed a lot of bleeding there, now you can see clearly. They want to do laser photocoagulation of some areas. That's the area. Most of the eye surgery is done through the pars plana to go into the posterior chamber. So pars plana vitrectomy indicated in cases of macular edema associated with tangential traction from the thickened hyaloid. That has to be peeled away. They will have now the opportunity, once you go through there, they have the opportunity now to peel away that fibrous tissue. they will have an opportunity to photocoagulate the new vessels which have grown there. Because once there are new vessels or new capillaries, they cannot just be pulled away. They're still having blood in there. So usually they photocoagulate them to clear them off. They will remove membranes through the pus plug. Lipid lowering drugs may reduce the requirement for laser treatment. See now. Pus plantar vitrectomy indicated. Yeah, okay, laser photocoagulation for proliferative diabetic retinopathy. Benefits of pus plantar retinal laser photocoagulation. Mild NVD with hemorrhage carries 26% risk of visual loss. Reduced to 4% with this pus plantar photocoagulation. I think what I was explaining here. Severe NVD. When we say NVD, it's neovascularization at the disc. You see? Severe NVD neovascularization at the disc without hemorrhage, there is a 26% risk of visual loss, reduced to 9% with the treatment once you ablate the new vessels. Severe NVD with hemorrhage, 37% risk of visual loss, but it's reduced to 20% with the treatment. Severe NVE. NVE is neovascularization elsewhere on the retina. And with hemorrhage, 30% risk of visual loss. With treatment, 7%. So you can see the variations, the need to go in and treat. You reduce the chances of visual loss from 30 to 7%. It's not a bad idea. Plus, everyone needs to have a good sight. You need a, you only appreciate that you need sight when you've lost an eye. Then you say, oh no, I really needed an eye. These are laser burns, a patient who had photocoagulation. You can see they are photocoagulating outside the macular area. These are the vessels, the temporal vessels. This is the macular area. You don't photocoagulate there. This is where the standard tip-top vision is. That's they say the top of the hill, isn't it? There. So you photocoagulate all around, and once the hill, it all scars. The picture looks like this. Weeks after treatment. It means they've hit all the growing new vessels there. Indications for laser photocoagulation in proliferative diabetic retinopathy. 1. Laser therapy is aimed at inducing the involution of new vessels, thereby preventing visual loss. New vessels, if you leave them there, they'll be bleeding. And once bleeding occurs, your vision starts going down. Later on, there is fibrous tissue formation, overgrowing of the tissues. So note, PRP, this is pan-retinal photocoagulation, influences only the vascular component, not the fibrous. So when you look at the fundus, you find there is fibrous tissue. Photocoagulation won't help. It's the vascular component. Once you do the photocoagulation, the vascular component disappears. But the fibrovascular part, the fibers, they remain. So PRP influences only the vascular component of the fibrovascular process. Eyes in which new vessels have regressed, leaving only fibrous tissue, should not be retreated because they are not achieving anything new, nothing much. If cystoid macular edema is present, laser treatment of this should be carried out prior to panretinal photocoagulation. This they do grid light bands. They do it in grid pattern around the macular area, that area like that. You do 1, 2, 3, 1, 2, 3, but in grid pattern. That reduces the cystoid macular edema. You do this before you go for panretinal photocoagulation. This can be done with this other treatment where you do intravitreal steroid or anti-vegetative endothelial growth factor agents, which improve the outcome. These are drugs which are there. They inject right inside, then they go on to do the laser. These are the laser settings. Depend on the contact lens used, Goldman lens, spot size that, panfundoscopic lens, spot size will be that, duration of the burn, all these you set, depending on the laser, the lens you are going to use. Power, so much. Sufficient, there must be power sufficient to produce a light intensity burn. If you are not sure, you start slowly and see. But usually people, when they go to that stage, they've had the training and they know what appears to be good power. They will set, no problem. If you haven't been doing this before, you need, this is something people will learn. The surgeons, there's learning from all the guys. Laser treatment in proliferative retinopathy. Initial treatment involves that 1,500 to 2,000 burns in a scatter pattern extending from the posterior fundus to cover peripheral retina in one or more sessions. In other words, you can do today, come next week again, you continue like that. It doesn't have to be one day until I finish, no. Follow-up after 4 to 6 weeks. In eyes with severe NVD, new neovascularization, new vessels on the disc, 3,000 of burns may be required. Okay, to involute for those vessels to disappear. So you're not going to do this in one session. You may do maybe 1,000, round. Maybe after some time, you will look at the patient again, you find some vessels are shrinking, come again, you do like that. 3,000 burns at a go is a lot. Signs that there is improvement, the vessels are disappearing, there's regression of neovascularization, leaving ghost vessels or fibrous tissue. The vessels start disappearing. What remains is the fibrous tissue. There is a decrease in venous changes, and there is absorption of retinal hemorrhages. You find the retinal hemorrhages which were there, they start being absorbed. That's good sign. Things are catching up nicely. And the disc pallor, the disc becomes pale. Those are good signs that the blood vessels are disappearing. But apart from that, you have to do complete checkout with a fundus lens to see whether actually the blood vessels are disappeared. They may take some time. You may go for retreatment again to clear them off. Treatment of recurrences, as I was saying, retreatment. Further laser photocoagulation is required, filling in any gaps between the previous scans. You go in. Or you use what is called intravitreal anti-vegetative endothelial growth factor. This is injecting this growth factor there. It is anti-vegetative endothelial growth factor. So it's against the growth of new vessels. We inject in the vitreous. Then after some time, you keep reviewing the patient. In most of them, all the vessels which are there start disappearing. So treatment of recurrences can use photocoagulation, where you push in areas which were left, or you go for intravitreal anti-vegetative growth factor, vascular endothelial growth factor, vascular endothelial growth factor, anti. This is against that. We inject in the vitreous. Diabetic eye disease. Advanced diabetic eye disease. You like you want the word advanced. Advanced diabetic eye disease, you have features of hemorrhage, which may be pre-retinal or retrohyaloid or intragel within the vitreous gel, and may also show tractional retinal detachment. This is advanced diabetic eye. They will show this is new vessels on the iris, especially the iris, the pupil margin. You find new vessels. That's what is referred to as rubiosis iridis. There we are. This is the bleeding, retrohyaloid between the vitreous and behind the vitreous and the retina behind there. That's retrohyaloid. Okay. This is advanced diabetic disease intragel. This is now the bleeding is within the gel, the vitreous gel. This is rubiosis iridis. At the pupil margin, you can see small blood vessels growing there. These are all features of proliferative diabetic retinopathy.
So can this be seen using the naked eye?
No.
On
This
the
is an eye.
Mm-hmm.
You have to see them with a slit lamp, watch up.
Sure.
Do we look with the naked eye to the lens? Mind you, you won't see much. No, you use a slit lamp. You should be able to see with a slit lamp. You know, you can see the light thrown across there. It's a slit lamp light. Where are we? Here. Oh, down there now. This is advanced diabetic disease, tractional retinal detachment. This has been there for a long time. There are no new vessels, but you can see fibrous tissue remaining and pulling the retina. This white stuff is fibrous tissue. Mm-hmm. This. So in such cases, okay, blood vessels, new vessels have gone, but this remains tractional. The fibrous tissue can lead to tractional retinal detachment. Pulling of the fibrous tissue pulls the retina off, then you have retinal detachment. Indications for pars plana vitrectomy. Pars plana is where? I think we've talked about the pars plana, isn't it? Mm-hmm. Mm-hmm.
You're asking for the location.
Yeah, where is it pars plana?
Ciliary body.
Ciliary body.
Mm-hmm.
The edge of the ciliary body as you transition into the retina. That's the pars plana area. There are no vessels there. If you are pushing, if you want to put anything in the vitreous, you normally go through the pars plana. And at the limbus, you go slightly backward. That's when you go in, you are in the pars plana. Okay. So if you're going to remove those that vitreous, that scar tissue behind, it has to go through. You go through the pars plana area, and you are in the vitreous. This pars plana vitrectomy can be done for severe persistent vitreous hemorrhage, which precludes the application of adequate PRP. If there is hemorrhage behind there, panretinal photocoagulation won't help you because you're not seeing the vessels. But once you go through the pars plana, you can get all that vitreous hemorrhage, you clear it. Okay? So vitrectomy usually done within 3 months of hemorrhage. Progressive tractional retinal detachment, threatening or involving macula, must be treated without delay. When there are fibrous tissue pulling and threatening the macula, you should go, this should be done straight. You go through the pars plana, and what are you going to remove? You remove the fibrous tissue. You peel out the fibrous tissue. Combined regmatogenous and tractional retinal detachment treated urgently, even if macula is not involved. What is tractional? It means there is fibrous tissue pulling the retina off. Okay, that's tractional. Well, regmatogenous is the retina is being peeled upward, fluid is being separated in between the actual retina and the choroid. The retina is detaching like that. Okay. So you can have a combined regmatogenous and tractional retinal detachment. These you should treat urgently, even if macula is not involved. The danger of subretinal fluid spreading quickly to involve the macula is real. There is now the fluid is pushing the retina off like that. So these must be treated urgently. By urgently, you and me who don't have the facility, it means we advise to send this patient to a center where they can do this. OTH, like that. Nga patient tanenako mundeke might be able to kunina kuendeka pamuntu ala kona ba saving akweninzo ya. Premacular subhyaloid hemorrhage. You can see that if not treated, danger of subretinal fluid even spreading to the macula. Once it is spread to the macula, your vision, central vision is gone. You know, so this should be treated urgently. Visual results of pars plana vitrectomy: 70% of cases achieve visual improvement, 10% are made worse, and the rest remain unchanged. 20% remain unchanged. So what this shows you and me is that while this is a good treatment, let us not give the patient that no, everything will be okay, everything will be okay. You tell them this is an operation, the outcome is this. Whether this is the outcome, it also depends on individuals like what we'll find there. Otherwise, if you give them a nice story, always telling them a nice, it's a small thing, we'll sort it out. Then you end up, it ends like this. Patient will say, might be even wanting to sue you. So give them real, stuff so that they understand. The chances of not improving is there. What we're trying to do is to help you so that our hope is that your vision will improve. But we leave that in the hands of the Lord. First of all, you can see 70% of cases achieve visual improvement, 10% are made worse, and the rest, which is 20%, remain unchanged despite the operation. Favorable prognostic factors are a good preoperative visual function. If they've got good vision before the operation, they've got a good chance of coming out nicely. Age of 40 years or less, not people like Dr. Mumbawa over almost retirees or over 100 years now. The chances are poor. Absence of preoperative rubeosis and glaucoma, and the previous panretinal photocoagulation to at least a quarter of the fundus. These, 40 years, they are good, In other words, a young person is in a better position, not only for this operation, for everything else. A younger man has got a better chance than an old man.
Go on.
Early treatment, diabetic retinopathy, study classification of diabetes. Yep. Go ahead.
10 minutes more.
10 minutes more. We'll do that. ETDRS is the early treatment diabetic retinopathy study classification of diabetic retinopathy. There was a study, I think, in UK where they did this, and this has been widely quoted in, Kansky, all these books. Category, description, and management. Non-proliferative diabetic retinopathy with no diabetic retinopathy. Management, you review every 1 year that patient. Once you do the photocoagulation, you review. Okay. Very mild, review. If they've only microaneurysms, review most patients in 12 months. Microaneurysms only, review. Mild, any of or all the microaneurysm retinal hemorrhages, you review 6 to 12 months. So it's not coming every week. Here we are talking of 6 months. But when you say 6 months, like any other disease, you should tell the patient that should the condition appear to get worse, you don't have to wait at, no, me, I was given a 6 months review date. If a patient notices things are not going well, you should be able to accommodate them when they come. This is standard, not only for this. That's how I treat all for any disease if you are in the clinic. There's nothing like Nishma Konka. Maybe that in after 2 months. No. First, listen why the patient has come. Maybe there is something wrong. And when you give them that long review date, tell them, but if you find that things are like this, you can come back. We shall have to squeeze you and have a look. Otherwise, you are going to have people, things have gone haywire, he's waiting 6 months. When he comes, he's blind. They've not achieved anything. Moderate, severe retinal hemorrhages. This is a classification of diabetic retinopathy. With severe retinal, the moderate, this non-proliferative diabetic retinopathy means they've got severe, moderate, severe retinal hemorrhages. Standard photograph, 2A and whatever. The quadrant, 1 to 3 quadrants or mild. Okay. Microvascular abnormalities, EMA, intraretinal. Significant venous beading can be present in more than one quadrant. What is venous beading? Like beads. Usually beading is because of poor flow of blood. You are going into ischemia. Early signs of diabetic retinopathy, proliferative. You have beading of some of the blood is stagnant. Like cotton wool signs. These are all early signs of the damage being happening there. The severe type, what have you got? You've got one or more of these. You have severe hemorrhages in all four quadrants, significant venous beading in 2 or more quadrants, or moderate EMA. EMA is intraretinal microvascular abnormalities in 1 quadrant. You review them in 4 months. But please, you give them 4 months. Give a patient room to come back if they see that things are not okay. For diabetes or for any disease you are treating a patient, that should be the standard, not textbook standards like this. I tell my patients, I can see you in 2 months, but should you find that suddenly you can come, we'll squeeze you in. And they have. Most of the time, because you said you can come, they might even not come. Very severe. This is the classification.
Okay, we are running 3 minutes.
3 minutes.
And now there's a question here.
Yes, let's hear the question.
Good morning. Sorry, I joined the lecture late. I don't know whether you talked about my question. My question is, among the 4 types of diabetes, which one is more harmful to the retina? From Malam.
Which are the 4 he's talking about first?
The 4 types of diabetes.
Which are the 4 he's talking about?
Apart from type 1, type 2. Is that one which also may result because of pregnancy? And another one, I don't know which one.
Let him explain, Kai.
Malambo,
tell us what you...
Switch on your audio.
So that we can all join in. Malambo, Karungwana Maria. Ashon. My Tonga friends. Ashon. A lot of Tonga friends.
Good morning, sir.
Mami, good morning. Yes, let's see.
Hello.
Hello, Mami, I'm hearing. I'm with you. Not clear from here.
Speak out.
Speak, Mama, speak. Is this a question? Oh,
the one she read out, say the 4 types of diabetes.
The 4 types of diabetes. Which are the 4 types she's talking about?
Malambo. Wow. Remaining with a minute.
A minute.
Serious.
Very severe. In the classification, you see the features and you say it's very severe. Right? When it's severe, you review in 2 to 3 months. But this is what I've been telling. Although it says 2 to 3 months, you must give room. What would appear to be mild can end up being severe. And if you restricted the patient at only 2 months, if you're in, the patient won't come.
So that's especially.
They should give room that if you think things have gone bad too early, come. You have to have room to squeeze a patient in. That way you treat more than sending them to blindness.
I think we can prepare another meeting just for questions.
Now,
We have less than a minute to be
okay,
cut.
prepare. Kaji.
So the slides remaining about
How many?
moderate PDR,
How many slides are remaining?
just two.
Two.
And
Advance. Either in one, you're in the one.
okay, get ready. We're preparing another meeting just for questions. Thank you.